Good day everyone, I am Christian Rosario Esperat, and in this report, I will explore reproductive health, examining conditions like ectopic pregnancy, abdominal pregnancy, Hydatidiform mole, and cervical insufficiency. So the goal here is to uncover their distinctive features and provide insights into their complexities and implications for maternal well-being. So starting off with ectopic pregnancy. What is an ectopic pregnancy? So an ectopic pregnancy is a phenomena that happens when the fertilized egg implants outside of the uterus. So at around 90% of ectopic pregnancy occur in the fallopian tube, also known as tubal pregnancy. But there's a big problem to that. The fallopian tube was not designed to accommodate a growing egg. And over time, it can cause the fallopian tube to burst, and that burst or rupture can cause major internal bleeding, which if left untreated can be life-threatening. So always remember that when the fertilized egg implants anywhere but the uterus, then it's an ectopic pregnancy. So speaking of ectopic pregnancy, I have mentioned that at around 90% of ectopic pregnancy happens in the fallopian tube. But what about the remaining 10%? Some ectopic pregnancy occur in the ovaries, the cervix, and into the peritoneal cavity. Which brings us to our next subject, the abdominal pregnancy. So an abdominal pregnancy is a rare type of ectopic pregnancy which happens when the fertilized egg implants into the peritoneal cavity, which is found in our abdominal area, hence the name abdominal pregnancy. So an abdominal pregnancy is classified into two, the primary and secondary. The primary abdominal pregnancy is an extremely rare phenomena that occurs when the fertilized egg implants itself in some abdominal organ or into the peritoneal cavity. While the secondary abdominal pregnancy, which is the more common type, happens when the fertilized egg implants itself first in the fallopian tube, the ovary, or into the uterus, and subsequently escape through a rupture and into the peritoneal cavity. So you might wonder why ectopic pregnancy happens. So there are several risk factors for ectopic pregnancy. So these include previous ectopic pregnancy, prior fallopian tube surgery, previous pelvic or abdominal surgery, STIs, and pelvic inflammatory diseases. So an ectopic pregnancy may manifest the same signs and symptoms just like any other pregnancies. Symptoms such as missed menstrual period, breast tenderness, or an upset stomach. And other signs may include abnormal vaginal bleeding, low back pain, mild pain in the pelvis or in the abdomen, and mild cramping on one side of the pelvis. So, as an ectopic pregnancy advances, so is its symptoms, especially if the fallopian tube ruptures. So, symptoms may include severe or sudden pain in the abdomen, shoulder pain, weakness, dizziness, or fainting. So, an ectopic pregnancy can be diagnosed with pelvic examination, ultrasound exam, and HCG testing. Now, what are the interventions for ectopic pregnancy? What are the things that we can do to address it? So there are two things that we can do. First, medication and surgery. So medication may be used if the pregnancy has not ruptured a fallopian tube. So common medication used is methotrexate. So this drug works by stopping cells from growing, which in turn ends the pregnancy. But during unfortunate time, when the fallopian tube has ruptured, surgery is required. But surgery can still be performed even if the fallopian tube has not ruptured. It is performed to remove pregnancy from the tube or the tube entirely. Common surgery that is often performed in this condition is called laparoscopy. Hydatidiform mole, also known as molar pregnancy, is a gestational trophoblastic disease. It is the excess proliferation of trophoblastic tissue found in our placenta. Trophoblasts are cells that forms the outer layer of the blastocyst, and it provides nutrients for the embryo and has major role in the formation of the placenta. A Hydatidiform mole occurs due to a chromosomal abnormalities of the trophoblastic tissue. During molar pregnancy, ACG levels are high due to the excessive proliferation of trophoblastic tissue. This proliferation can be either non-invasive or invasive. The Hydatidiform mole is divided into two, the complete mole and the partial mole. The complete mole occurs when an empty ovum is fertilized by one sperm, which occur 90% of cases. The chromosome will duplicate and give karyotype of 46XX. Sometimes a complete mole occurs when an empty ovum is fertilized by two sperm, which gives it a karyotype of 46XX and 46XY. A partial mole occurs when an ovum is fertilized by two sperm, and this will give a karyotype of 69XXY, 69XXX, and 69XXY. Complete mole is diploid, while the partial mole is triploid. In complete mole, the karyotype comes from the father, so it's paternal, while in the partial mole, the chromosome must derive from both parents. In complete mole, there is no fetus, but has a proliferation of swollen chorionic villi. So as you can see, it looks like grapes. In a partial mole, fetus is present but is abnormal. So 15% of complete mole progresses to GTN, while 0.5% of partial mole progresses to GTN. So now, what is a GTN? So GTN, or gestational trophoblastic neoplasia, are the invasive types of GTD. Still, the ACG here are high. So types of GTN. So there are invasive mole, choriocarcinoma, and placental site tumor. In invasive mole, the invasion is only and limited to the uterus. Whereas in choriocarcinoma, the invasion goes beyond the uterus and can metastasize. And in placental site tumor, it is a rare type of GTN that arises from the placenta. It tends to invade the uterine wall and blood vessels but is usually more indolent as compared to choriocarcinoma. So risk factors for a molar pregnancy are reproductive age, previous molar pregnancy, and being an Asian. Yes, you heard that right. Being an Asian is a risk factor. Because according to studies, Asian descent is linked to a higher risk of H-mole, especially in Southeast Asian populations. The exact reasons are unclear and might involve genetics, environment, or lifestyle. However, not every person of Asian descent will experience this, as individual risks vary due to multiple factors. So now going back, patients may present with an enlarged uterus, ovarian cyst due to high levels of ACG, nausea and vomiting due to high levels of ACG, and preeclampsia. So preeclampsia is a disorder of pregnancy in general. So normally they would present in 20 weeks, but if preeclampsia occur early, it might be a sign of molar pregnancy. And also hyperthyroidism. Since HEG and TSH are similar in structure, so when HCG level spikes, it mimics a hyperthyroidism spike state. So how do we identify an H-mole? So we identify an H-mole through its HCG levels and ultrasound. Snowstorm appearance can be seen or identified when we ultrasound a complete mole. For the intervention, ERPC is advised. ERPC, or evacuation of retained products of conception. It is a type of dilatation and curettage that focuses on removing retained products of conception from the uterus. After that, the patient should have follow-up serials of HCG to check if the patient has persistently high HCG. And if they still have high HCG, then it implies some pregnancy tissue, remains or that there is new pregnancy. Then after that, they would be diagnosed with GTN, which will require chemotherapy. Chemotherapy is a common treatment option for persistent trophoblastic disease, which can occur after an ERPC for molar pregnancy if HCG remains elevated. Chemotherapy drugs are used to target and eliminate the abnormal trophoblastic cells. So, as I have mentioned earlier, methotrexate is a drug that works by stopping cells from growing, and that also applies here. Methotrexate is often a first-line chemotherapy regimen, and duration depends on factors such as the extent of the disease and the patient's overall health. Cervical insufficiency is a painless cervical dilatation and is recurrent that leads to the delivery of the baby that is still in its second trimester. The delivery is caused by the structural weakness of the cervical tissue, and that leads to a premature opening of the cervix, which results in premature labor and eventually premature delivery. In most cases, women are asymptomatic, and if they do have symptoms, it usually is very mild. They experience symptoms like pelvic pressure and backache. So these symptoms are felt between 14 to 20 weeks. So what are the risk factors? There are two types of risk factors for cervical insufficiency: the acquired and the congenital. The acquired risk factors happen to those individuals who have prior history of preterm birth less than 28 weeks, cervical lacerations or obstetric injury, and cervical instrumentation like hysteroscopy and dilatation and curettage. So while the congenital are the conditions that are present from birth, so individuals who have conditions like uterine anomalies and collagen disorders. So collagen is very important because it helps with the integrity of your connective tissue, one of which is the cervical tissue. But always remember that having symptoms of preterm labor does not necessarily mean that you have cervical insufficiency. So there might be other explanation to that. It might be maternal or fetal infections, bleeding and placental disorder, uterine distension, fetal disease and maternal disease, and so on. So there are so many variables involved. Now, how is it diagnosed? So cervical insufficiency is very difficult to diagnose, especially if it's your first time having a child. It really is an advantage if it's your second time around, because if you already have a history of cervical insufficiency, then your doctor would know what to look out for. So basically, the index of suspicion would increase. So usually, the doctor would review your medical history, do serial monitoring of cervical length, and perform pelvic examination. So the normal length is around 3.1 to 4 centimeters. So if it shortens to less than 3 centimeters or an opening has been noted, then the doctor would advise an intervention. So for the intervention, various treatment for cervical insufficiency have been suggested, both surgical and non-surgical. So non-surgical methods like activity restriction, bed rest, and pelvic rest have shown limited effectiveness and are not recommended. Vaginal pessary is a non-surgical option considered for patients at risk, although evidence supporting its benefit is limited. So the preferred intervention is through surgery, a cervical cerclage. It is a surgical procedure that can be used to help manage cervical insufficiency. It involves the placement of a stitch or suture around the cervix to provide support and prevent premature opening or dilation. So if you want to know more about the specific types of cerclage, you can click the link below that I pasted for deeper understanding.